Okay, good morning, everyone. Welcome to Grand Rounds, our last Grand Rounds in the month of June. I will kind of wait for a few more participants to enter from the waiting room as everyone kind of piles in. We actually, thankfully, don't have a lot of announcements this morning about either COVID or other things, and so we'll have more time for our speaker this morning. I will want to remind folks. So next week's Grand Rounds, if we could show the slide. So it's going to be Dr. Jeffrey Glenn. Usually the first Grand Rounds of the month is in person, but next week, coming right after the 4th of July holiday, we're actually only going to be Zoom only. So please don't come to LKS. You'll be very lonely there. It will be on Zoom only next Wednesday. So Dr. Glenn will be speaking. He is a professor of gastroenterology and hepatology here in our Department of Medicine, as well as a professor of microbiology and immunology. So join us next week on Zoom only. And with that, it is my distinct pleasure to introduce our speaker for this morning, Dr. Marshall Chin. Dr. Chin joins us as the Richard Parrillo Family Distinguished Service Professor of Healthcare Ethics at the University of Chicago. He is a practicing general internist and health services researcher. He's dedicated his career to advancing health equity through interventions at all the levels: individual, organizational, community, and policy. And through the Robert Wood Johnson Foundation Advancing Health Equity Program, he collaborates with teams from the state Medicaid agencies, Medicaid managed care organizations, frontline delivery organizations, as well as community-based organizations to implement payment reforms and support and incentivize care transformation that will advance health equity. He co-chairs the Centers for Medicare and Medicaid Services Healthcare Payment Learning and Action Network Health Equity Advisory Team. He also co-directs the Chicago Center of Diabetes Translational Research and is associate director of the MacLean Center for Clinical Medical Ethics and applies ethical principles to reforms in service to advancing health equity and discussions around advocacy for our patients. We have a number of actual graduates from the MacLean ethics program as well that are part of our ethics department here. Dr. Chin, he's a graduate of Harvard College and the University of California, so UCSF, School of Medicine just up the road, and completed his residency and fellowship training in general internal medicine at Brigham and Women's. He is former president of the Society of General Internal Medicine and was elected to the National Academies of Medicine in 2017. And Dr. Chin was one of the reasons I started going to Society of General Internal Medicine conferences at my first academic national conference when I was a resident, who was speaking about diabetes and the management of chronic illness. And I remember kind of being inspired in the practice of internal medicine and taking care of and advocating for our patients. So without further ado, Dr. Chin.
Yeah, thanks so much, Stephanie, for the very generous introduction. I'm going to do share screen here, and hopefully the slides will pop up. Okay, great. Yes. And so been really looking forward to this talk, the opportunity to spend a good amount of time engaging in what I think is an important discussion about some challenging topics. I have an ambitious agenda for us over the next 45 minutes or so. And this time at times could be challenging, and a variety of sort of tense, difficult issues being discussed. One of my goals here is really to have everyone have hopefully at least one aha moment regarding the way that you think about healthcare and health equity. And hopefully then this will be a way of helping everyone in their journey for learning about health equity and advancing a paradigm for thinking about equity and anti-racism. So specific learning goals are, first, to recognize the role of racism in care and policies related but distinct from inequities and social drivers of health. Second, to identify how racism affects care at multiple levels. Then third, to describe challenges and potential solutions for anti-racist approaches to payment reform and care transformation. I'd like to start with a story that about a year and a half ago, It's in the General Internal Medicine Clinic, and I was taking care of one of my long-standing patients. This person is a retired University of Chicago professor from the social sciences. And hopefully, as we get older, we become wiser. And this professor is someone that was always wise and is maybe progressively wiser over time. And I asked him, usually there's these appointments, we will spend time talking about non-medical things as part of it. I asked him, well, what do you think about the country? This is like a couple of years ago. And he said, Marshall, to be honest with you, I may be a cynical old man, but I am deeply concerned about the country. And I remember he mentioned three things. One was the large amount of income inequality we have in the country. The second was climate change and the lack of action upon this. This was just being before, I think, the Biden administration reforms. But then third, he said that we have to have two sane political parties in our country to function. So, both parties have to be sane. And, he just sort of raised existential questions that I think that we would all agree that this is a contentious time in our country. And there are some really existential questions regarding how we're going to develop as a community and as a country. So we are at this turning point in a sense. I'd mention also too that like within the equity field, it's both a time of great opportunity. I mean, people talk about this as like a window of opportunity to potentially get a lot done. And I actually think this is a great opportunity and time to be doing equity work. At the same time, it is a time of great danger also. We're seeing a lot of pushback regarding equity issues in general. And there's a variety of folks nationally and in the sciences and in academia that have a great concern with the public's mistrust of science and the idea of alternative facts and alternative ways of looking at objective facts and reality. So it is a dangerous time also. So I mentioned that one of the things I do is that I co-chair this health equity advisory team for the Centers for Medicare and Medicaid Services. The other co-chair is Karen Dale, who is a nurse by background, and she's the CEO of AmeriHealth Caritas DC, which is a health plan in the DC area. And Karen's great, that she's smart, she's a great communicator, has a really deep understanding of organizational change and what makes people and institutions tick. And one point she makes is that in the health equity field, that she's concerned that we may be seeing a lot of performative virtue signaling actions. In other words, that equity has now become like sort of like the popular thing. If you look at any institution's mission statement, almost all will have some type of patient-centered statement. And then a lot of groups are doing health equity work. The degree, though, that there is true patient-centeredness, authentic community engagement, and a true commitment to equity, that's a big question. And to what extent institutions are doing more checkbox actions as opposed to substantive, authentic actions to advance health equity. So again, I think we were at this sort of turning point of what are we going to be and what are we going to do? And the last sort of upfront story I'll share is that there's this issue like, do we have incremental change, incremental innovation, or disruptive innovation? And I would argue that, like in general, and especially in health equity, we need disruptive innovation. So one of my collaborators is a brilliant Israeli organizational sociologist, Sivan Spitzer. And a couple of years ago, Academy Health, which is the major professional association for health service researchers, asked us to commission us to do this paper, which was designed to help them think about what does the health services research field want to be over the next 10 years. So again, it's sort of like not now, but like, in a forward-thinking way, where should we be headed? And this really applies to any given field, this particular question. And Sivan, she is like this Renaissance woman that knows a lot about a lot of different things. And so you see in this diagram, she has this idea about a research discipline. And we'll take health equity as an example. In the middle, you have like the internal aspects. And I would say that in health equity, we have sort of evolved from a health disparities lens to what is a health equity lens, which I'll describe shortly, which I think is good and okay, but not enough. And so within the field, in any given field, there's this tension between sort of the dominant paradigm of the field as it matures, and then, the rebels, so the people with the opposing views who want to take it to the next level internally. At the same time, there are external forces. And I would argue that in the past 3 years or so, maybe the two biggest external forces that have affected the health equity field have been George Floyd and police brutality, and then the COVID-19 inequities. And what this did for raising structural racism, awareness of structural racism within the general public as an issue and a driver of equity issues. So anyway, there are both these external factors and internal factors, and then how our field responds can differ. And so you see at the far right, there's this issue of incremental change for sustaining innovation. And Stefan gives us example of digital humanities. So, I'm old enough that I trained in an area where actually my senior year in college, that's when the first Macintosh computers came out. I remember then, when you do the humanities, you would read a novel or you would read a text and you do analysis from that. And Sivan makes the point that, in the ensuing 30 years now, the world's become digitized. And so a lot of humanities texts and resources now digitized. However, the way that the humanities professors in general study is incremental. So now that you have easier access to these different materials, but it's basically the same methods of analysis. And then she juxtaposes this to what she would call an example of disruptive innovation. So the example of musicology. And so traditionally in musicology, you might for example, study the note structure of a composition, or if you're a jazz enthusiast, you might analyze a jazz riff and what happened there. She gives an example of some music studies that use the African-American studies as an example, brought together different disciplines. So an African-American studies department or center would have then humanities folks, history folks, political scientists, music people, health people, a variety of folks. So that led to a fundamentally different set of questions. So for example, one question example she gives is the idea of analyzing, for example, you go to a concert, a classical music concert, and you see what's on the program. Why is it that particular choice of composers and that particular set of choices regarding the particular songs and compositions, who is underrepresented in that? So this is an example of disruptive innovation and how it leads to a different set of questions. And again, we're going to sort of push towards this as a disruptive innovation. So I will talk a little bit where I'm coming from, my positionality for this talk, observations and a paradigm shift. We'll go into definitions of racism, equity, and social drivers of health, discuss a roadmap to advance health equity, and then spend most of the time talking about anti-racism challenges and then solutions. And I hope that we have a lot of questions in the discussion that, as telling Stephanie, that the talk has not succeeded if there are not a lot of questions in during conversation when my talk ends. So as Stephanie said, I'm a clinician, I'm a general internist, so I do both outpatient work and 1 or 2 rotations on the inpatient service each year. I do a lot of multi-level intervention research. I direct a number of these national programs. The thing I want to point about that is that I've been very fortunate then to see a lot of people doing equity work all across the country. It's quite humbling that you realize that there are incredibly good people doing incredibly innovative, hard work everywhere. And I'll give you some examples of that in the course of the talk. So this both humbling and then also very inspiring just to see so many good people in this area. We've done about a dozen reviews of systematic literature on health equity interventions. We're in about year 10 of our own journey at the University of Chicago regarding equity. And then I go to a lot of national meetings and serve on a lot of national committees. So I have a pretty good pulse of what's happening nationally. So this is the young Dr. Chin. And so I grew up on the East Coast, UCSF, Brigham, and then been in Chicago since then. And this is a typical patient of mine in the clinic. So middle-aged African-American woman with multiple chronic conditions. And, I think you see just by the visual that, there's some cultural clashes here. And, I was acutely aware of these as sort of a new clinician, a new faculty member in Chicago, despite taking care of diverse populations, both in Boston and in the Bay Area. Part of his family background, that my mom and dad, immigrant family, they come from a large family, 8 and 10 siblings each. It's a picture of my mom and dad's wedding. My mom's side was noodles and my dad's side was laundry. And so left to right, that's Uncle Winthrop, my grandfather, Uncle Roger, Uncle George, Uncle Gilbert, who all worked in the laundries. And a lot of my aunts and uncles were very talented, bright people, but most of them had the bamboo ceiling where they had limited opportunities because of their race and ethnicity. This was not a particularly good time to be growing up a Chinese American in the country, and it's, you know, a long history then of discrimination against the Chinese and Asian Americans. And so I was acutely aware of this as a kid, you know, going to Chinatown every Saturday to see the extended family. So I think those issues sort of stuck with me and contributed to my interest in health equity. And then at UCSF, I did most of my rotations at San Francisco General and the VA. And, you know, as we all know on this call, anyone in training sees it right away in terms of health equity issues. And so that became, you know, it's very important to me. Okay, observations and paradigm shift. So about 2 years ago, NEJM invited me to do an editorial on this topic of COVID-19 and chronic disease care. And I entitled the editorial or perspective piece, Uncomfortable Truths, What COVID-19 has Revealed About Chronic Disease Care in America. About 6 years ago, my wife and I, we started training and performing both improv and stand-up comedy. And Keegan-Michael Key is one of my favorite comedians. And I actually start this NEJM perspective with a quote from him that if you Google him, one of the things that comes up pretty quickly is a YouTube interview of him. And he's a very smart, thoughtful man. And he talks about improv, and he says that jump off the cliff and figure it out on the way down. People think improvisation is moving forward. What improvisation is backing up that gives you discovery. You back up, you can create a larger worldview. So, you know, improv 101, we're taught that what gets you into trouble is if you just are thinking ahead, that if you're so concerned about the funny thing you're going to say next, you don't truly listen to what your scene partner is saying. So this point about like being in the moment, truly listening, backing up, observing, that gives you discovery, that helps you understand and create a larger worldview. And so when COVID happened, I think a lot of it was the sense that, well, yeah, we're falling off the cliff, that it was urgent. We had to set a move, we had to have action. But again, I think the same sort of perspective, if you then stop for a moment, observe, and then take a step back, you know, there are a number of lessons then from COVID-19 regarding equity. The first is that the US healthcare system excels at perpetuating its basic structure and supporting the powerful stakeholders who profit from the structure. So, you know, one example is that just how we basically reward surgeries, procedures, and we undervalue the cognitive aspects, or things like coaching on self-management and addressing social needs and human relations connections. If you haven't seen it, in the past week, there's a devastating JAMA viewpoint that just came out by Bob Emerson and Zeke Emanuel called The Medicare Physician Fee Schedule and Ethical Behavior. Quick read, well worth doing, basically this particular issue. Second, the current financing and reimbursement systems do not adequately support the improvement of population health. So one of the examples that was just current at the time I wrote the perspective was so aducanumab. So, you know, expensive medication that not evidence that it works and it has serious side effects. At that time, the cost of a year of aducanumab was equivalent to the cost of a home health aid. But of course, what do we invest in as a society? Well, you know, that particular drug. And then third, the US chronic disease system are inequitable. The healthcare system will continue to put people experiencing poverty and other marginalized populations at the back of the line unless we intentionally value and address their health. Or as the feminist Audre Lorde said, the master's tools will never dismantle the master's house. So again, this idea of disruptive change and how incremental change may not cut it. So definitions. Now, one of the reasons I want to go over definitions is first to make sure we're all on the same page, because I think sometimes people use common words differently, but also I think sometimes people will use words like equity and social drivers of health as a euphemism for racism. So I want to just very clear cut and explicit about this. And this is very timely that last year, for the first time, NIH issued some requests for applications on structural racism, and had a specific conference, NIDDK, on addressing structural racism in kidney health disparities. For me, the way that has been most helpful and practically useful for understanding and talking about racism is Kamara Jones's 3 levels. She has this great American Journal of Public Health article, Gardner's Tale, used as Gardner's as an allegory for this. She provides a global definition and then 3 levels of racism, which we'll go over. Her global definition is that racism is a system of structuring opportunity and assigning value based on a phenotype or race that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, It undermines realization of the full potential of the whole society through the waste of human resources. She then talks about internalized racism, defined as acceptance by members of the stigmatized races of negative messages about their own abilities and intrinsic worth. It is characterized by their not believing in others who look like them and not believing in themselves. So in her talks, Kamara gives the example of white man's ice is colder. So, African-American person saying that, and, of course, ice is cold no matter where it comes from, but the idea that ice is being sold by the white man, well, it's being sold by the white man, therefore it's got to be better, got to be colder. Personally mediated racism, and this is the type of racism that I think most people think of intuitively when they heard the word racism. Prejudice and discrimination, where prejudice means differential assumptions about the abilities, motives, and intentions of others according to their race, and discrimination means differential actions toward others according to their race. Personally mediated racism can be intentional as well as unintentional, and it includes acts of commission as well as acts of omission. And then finally, this is the third one, which is maybe the newer one in the field, and the one that I think a lot of organizations are starting to have the hard inward look at, so-called institutionalized racism. Differential access to the goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes legalized, and often manifests as inherited disadvantage. It is structural, having been codified in our institutions of custom, practice, and law, so there need not be an identifiable perpetrator. Indeed, institutionalized racism is often evident as inaction in the face of need. Institutionalized racism manifests itself both in material conditions and in access to power. I think this is the first time I've mentioned the word power in our talk, and this will be sort of our current theme as we go on. And then also another key concept, intersectionality, the combination of intersecting systems of oppression that perpetuate discrimination and disadvantage based on factors such as race, class, sex, and gender identity, which you all know from Kimberly Crenshaw's work. So again, to point out that racism is related but different than equity and social drivers of health. So equity, I like this visual. This is from the Robert Wood Johnson Foundation. Equality, the top half, everyone receives the same bicycle, regardless of whether that particular size bicycle would fit their needs. Equity, each person gets the appropriate vehicle to maximize their function. They actually updated this figure. So this is the current one, equality on the left, and then equity on the right. Everyone gets what they need, understand the barriers, circumstances, and conditions. Then I like the World Health Organization definition, which adds social justice. So they say equity is the absence of avoidable or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Health inequities also entail a failure to avoid or overcome inequalities that infringe on fairness and human rights norms. We'll get back to some of these ethical principles a little bit later. So I mentioned this CMS group that Karen Dale and I co-chair. And so when we kind of, with our definition of equity, we basically took the US Healthy People 2030 definition, and then we added racism. So the definition being the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focus and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, which includes systemic racism, and the elimination of health and healthcare disparities. So this definition you see, I think, incorporates the prior ones we just went over. Social determinants of health, which I like to call social drivers of health because determinants sort of have this fatalistic feel to it. Social determinants of health are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social drivers of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries, WHO. There are different models of SDOH. This is the World Health Organization, and they're all fairly comparable. So you see, for example, they divide these 5 different elements: socioeconomic and political context, something like labor and housing policy, socioeconomic position, like your social class or gender, social cohesion, social capital. So, for example, do you live in a chaotic neighborhood or one that has a lot of community cohesion? Maternal circumstances. So, for example, do you have warm clothes and a good physical work environment? And then healthcare itself is one of these social drivers, such as access to healthcare. Already mentioned this. So a lot of what I'm talking about next is drawing upon this experience from the RWJF Prevention Program and some of this CMS work. So this is my attempt in one slide to basically summarize health equity interventions, what we know and how to progress. At the very top, you see that we all have to commit to the mission of equity and intentionally advancing health equity. So this intentionality aspect to it, that it just can't be, oh, we're just going to rely upon a generic approach. It has to be intentional in terms of targeting equity. And then I mentioned, the Karen Dale quote about, are we being performative and versus signaling, or are we truly committed to the mission? Because that's what's going to take for sustainable change. In the middle, you see this thing, implement the roadmap to reduce disparities. And so, there is this process by which typically you look at your data and then you identify where there's a disparity in care or in outcomes between more and less advantaged populations. With the community you're working with, you do a root cause analysis to understand what causes those disparities. And again, with the community, you design and implement care interventions that address those root causes. On the far left, you see this issue of culture of equity. We've learned this the hard way. If you just focus upon the technical things like those roadmap things about the root cause analysis interventions, and you don't pay attention to equity, you will rapidly reach the wall. And it sort of gets this issue of that you have to have everyone's buy-in and leadership buy-in and their commitment. Otherwise, you're not going to have the resources and buy-in and support to basically succeed. And so the culture includes both the inwards look, understanding your personal biases, and then your institutions, so a Chicago or Stanford, trying to understand and identify the system structures that bias against and oppress marginalized populations. In the middle, you see this very important factor that where it hits the road. And, in some ways, it's the litmus test is that, if you can answer this question to the people you're working with, to like the frontline worker, where they actually know how to operationalize advancing health equity in their daily jobs, you would have succeeded. Ultimately, at the bottom, improving health and health care equity. On the far right, you have two big sort of like uber issues. Payment reform, and again, it's not payment reform for payment reform's sake, but it's payment reform that supports and incentivizes those care transformations that advance health equity, and the idea of cross-sectoral partnerships to address medical and social drivers of health. Both individual drivers, so most places now, or well, not most, I say increasing numbers of places, health organizations, they'll try to screen patients for health-related social needs. So they'll screen people for food insecurity, screen people for housing insecurity, which is, again, related but different than partnering with community to address the structural driver. So partnering with a community-based organization to address the problem of homelessness in Chicago or food insecurity in the Bay Area. And one of my take homes from this particular part in terms of intervention is think multi-level, think intersectionality, think context and nuance. And we can do better in the translation of the 30,000-foot macro concept of racism to how it affects persons and communities and how anti-racism interventions can succeed. We need to do a much better job of connecting the dots more tightly. Again, this idea of like, well, okay, we can talk about anti-racism, but what does that mean for the frontline person in the field, whether it's in the clinic, whether it's in the community, whether it's in the finance department, whether it's in strategic operations, so they know how to operationalize that. We talked about that, the mantra. So, it could be a whole different talk, sort of going over the interventions that have been shown to improve health equity. For those who want a much deeper dive, I refer you to this particular paper from last year in one of the endocrinology journals here. It's an entertaining read. I sort of incorporate a variety of cinema stories in this one. But anyway, I think it evolves in so much. It's not rocket science that like the things that work for improving equity really summarize down to like the first bullet. Those interventions that enable you to have a close relationship with the patients and that holistically address their medical and social needs and enable close follow-up and monitoring. So, the principles of good primary care or team-based care. So, some of these elements include things like multifactorial interventions, culturally tailored interventions, team-based care, a lot of good evidence, for example, these nurse-led team-based interventions. Community health workers is one of the most robust evidence bases for, and not surprisingly, involving families and communities in these solutions. So now I'm going to shift now specifically to the racism component in terms of the challenges and then the solutions. So I'll go over 3 challenges here, which we'll go over one at a time. So the first is the lack of an intentional anti-racist lens. And so you remember that other diagram, that one-page summary, I talked about how we have to be intentional about equity efforts. And I would add on to that, intentional about talking about structural racism and anti-racism. So anti-racist lens is both the content, what is discussed, as well as the process. So are people and communities of color at the table, and is power shared? And so I think when you start applying that level of accountability, then most institutions don't measure up very well. Commonly, I hear what I would call magical thinking, where they say, oh, Marshall, don't worry about it, we have it under control. So for example, if I had, the penny for every time I hear this, I'd be a rich man comment. People will say, well, we're already doing quality improvement, and by definition, doing quality improvement will lead to reduced health disparities. Or we're a safety net organization. I mean, we work in a fully qualified health center. We work in a safety net hospital. So therefore, by definition, it's equity work, and it's who we are. Or another common one is the shift from fee-for-service payment, the value-based payment and alternative models. Well, it'll fix things. And the answer to all of them is not necessarily so, because you could have a lot of unintentional negative consequences and a lot of problems unless you intentionally design your efforts to advance health equity and then you intentionally address anti-racism. We talked about saying, like, you've heard in the QI field, of rising tide lifts all boats, but not necessarily. And so this idea that having to be just very carefully thinking about all the different populations and the drivers of the outcomes and what needs to be done for each population. Trustworthiness, it's a big effort right now nationally. American Board of Maternal Medicine, among others, I think AAMC, this issue of trustworthiness in relationships at the level of both the clinician and patient and the level of the healthcare system and the community. So a couple of these parables, you've heard that progress moves at the speed of trust, or I am told this is an African proverb: if you want to go fast, go alone. If you want to go far, go together. Which, to me, in my experience, there's a lot of wisdom in that particular comment. So what's going on here? So one of my collaborators, Monica Pico, learned a lot from Monica over the years. She did her residency at Stanford, and she continuously waxes about the wonders of the Stanford residency program. So I know well how strong the training program is at Stanford. She's a great proponent. But anyway, like one of Monica's fields is like clinician-patient communication. So you see at the bottom of this diagram that there's in some ways like what is verbally said. So we're communicating, we're doing our shared decision making, we're saying things. At the same time, there's the upper half of the diagram of what's in our heads, the things we're not saying, but which are in our heads. And there's both some of the internal biases we have about ourselves, some of that internalized stigma type of thing, for example, as well as the biases we have of the people we're talking with. So there is this delicate dance that's going on regarding trust. And any experienced clinician knows this, that like we're constantly sizing up the patient, and then simultaneously the patient is constantly sizing us up. It's actually sort of an analogy to stand-up comedy where we're taught to read the room, in terms of trying to read the room. At the same time, the audience is trying to read us, and they're making assumptions about us based upon our appearance and presentation and the way we enter as a comedian. So anyway, trust is the big part of this that has to be addressed. And the problem is that people of color have significant distrust and mistrust of the healthcare system. They have lower ratings of patient experience measures. And in general, health professional trainees aren't well trained regarding addressing racism and implicit bias. And then a lot, here's one, is a talk in itself that, a lot of communication and clinician-patient relationship training tends to be very structured. My medical education colleagues talked to me about like both the strengths as well as the tyranny of the OSCE, for example, and the checkbox mentality, which have been encouraged by some of the accreditation standards, as opposed to, again, what any clinician knows, that in reality, what we need to meet patients with where they are at. Something like motivation interviewing, we're meeting people where they are at, which is more complex than in some ways the easier measurable requirements that often are instituted by the accreditation organizations. The third is the big one: the power and systems of oppression, the need for free, frank, fearless discussions. So for me, maybe like one of the hey, I have to even go far as like life-changing sort of events to me in the past 6 years was I spent a summer in Aotearoa in New Zealand. And so I highly recommend if at some point in your career you become mid-level and whatnot, if you have the opportunity to do some type of mini sabbatical, it is so incredibly helpful for the reason why travel, one of the reasons travel is helpful for anyone, right? Of like just giving us a different perspective. And so I spent 3 months in the country, and we were working on this paper comparing the U.S. and Aotearoa, New Zealand, on what they're doing for health policy. And actually Sarah Singer's on this call, and one of our collaborators, we met actually through Sarah Derrett, who is the woman in the upper right, who is my mentor in New Zealand for this particular project. The three people on the left, they're all Maori, the indigenous peoples of Aotearoa, and they're co-authors. And I learned so much from them that we had literally dozens of these so-called free, frank, fearless discussions where they were very open with me, and they would challenge me. And so this point about like colonialism, so we don't talk a lot about colonialism in the U.S. I think after my time in New Zealand, I finally have a foundation for thinking about colonialism. So they basically taught me that system of oppression, when you do the deep dive into it, the ultimate issue is that power is the issue. So it's control over like money, control over resources. It's control over the historical narrative. And so we're seeing this a lot in the US right now, where a lot of these so-called culture wars and a lot of laws being passed by some of these states really have to do with trying to control the historical narrative. My wife is Japanese, and so we see this too, like for example, like the Japanese government trying to create an alternative story of World War II, or in the U.S., for example, then like euphemisms like calling the U.S. Japanese American concentration camps relocation camps or internment camps. So partly it's also been this issue of control over the framing of health equity. So again, these discussions about structural racism, colonialism, and various forms of social privilege. So many of you probably have heard of Robin DiAngelo. She's a white sociologist, and she had this book that got a lot of attention. White fragility is this term she coined, that this idea that racial stress can lead to defensive emotions and behaviors in whites such as anger, fear, guilt, argument, silence, or withdrawal. And what my Maori colleagues told me was that for them, what it is, it's basically a distraction. It's a political distraction. It's another way of basically kicking the can down the road so the issue's not addressed. So they basically, they put this line in our paper, discomfort cannot be a reason to avoid dialogue, for then white fragility would in essence be a tool to perpetuate inequities in the power structure. And again, these talks, they basically sort of gave me example over example of like how colonialism and racism had led to then the inequities that are seen now for the Maori in Aotearoa, New Zealand. So now solutions, and I'm going over 5 solutions here. And I love this part too, because so often they talk about problems and they leave 3 minutes for solutions. So I'm going to try to go into some detail here with a crack at this. And we haven't solved everything, and these are hard issues, but here's a crack at what I think maybe some promising avenues for us to explore. So first, look for racism, search explicitly and be intentional about anti-racism in the solutions. So the problem, the word that comes up is invisibility. So this is my wife, Naoko. And so we had a paper fairly recently about invisibility in the Asian American community. That one of our problems, Asian Americans, Native Hawaiians, Pacific Islanders, is that we don't count. We're invisible. We're not, no data about us. It's not collected. And then we're not high priority in terms of the issues of discrimination against Asian Americans. So it's the idea that unless we're intentional about looking and collecting the data and addressing issues, then, we'll be overlooked, And so I have to admit, like, for our Robert Johnson Foundation program, I think we've done a lot of good things, and there's some areas where we could have done better. So Scott Cook, who's the co-director of the program with I, he led I think a very thoughtful paper that came out recently in American Psychologist. So one of the points he's made is that like in our program for many years, and I think the current equity field has what we would call a general equity lens. So we would ask a question like on the far left, why do Black children with asthma have higher rates of hospitalization than white children with asthma? And this should feel familiar to you because this is the general teaching within the disparities field. Like you look at your data. So at Stanford, you look at your asthma admissions and ED visits, you stratify by race, ethnicity, and you see, well, for example, is there this issue where Black kids have higher rates of hospitalization than white kids with asthma? The problem with that, though, is that the wording takes you down a certain route where it can lead to a blame the victim approach, where you start focusing your interventions maybe too much in terms of like the patient factors and the family factors and all. When you look at the literature, the vast majority of interventions in equity literature are sort of patient driven. And there's a lot of good things for that. Being patient is very good, but the downside is that there's relatively few systems and policy interventions as compared to patient interventions. So for example, on the right, if you worded the same issue with the following wording, why is our health system less successful helping Black children with asthma avoid hospitalization than in white children with asthma? It takes you down a different route in terms of questions and potential solutions, and it leads you more towards being broader regarding your approach and the things that the Universal Chicago healthcare system and the way Stanford is set up is system for kids with asthma can do better regarding equity issues. So Scott and Yelena on the far right, they're left me politically. Sivan probably is also. I've learned a lot from them, and in particular, like Scott and Yelena, it took them really a year of discussions with Sivan and I for us to understand what they were talking about, because it's a different language and different sort of way of viewing the world. And so I would say again, like we have been approaching things for the longest time with on the far left, care transmission and payment performed with equity lens. Whereas in the newest iteration of our Robert Johnson Foundation program, we've gone to the right-hand side, care transformation and payment reform with a critical consciousness and anti-racism lens. And let me talk about that in a little more detail. So critical theory, it emphasizes power analysis as an approach to understanding and transforming structures by targeting the root causes of social injustice. Structure refers to political, social, cultural, historical, and economic forces that influence individual behavior and thus create predictable patterns based on social locations. And again, maybe the easiest way to understand this is like, it's basically replicate what I was doing with our Maori colleagues. If you're able to engage in an honest discussion with any person from a marginalized group, this will come up if it's an honest discussion. Critical consciousness, the ability to read the world critically and take action to transform it. This fancy word praxis is the ongoing process of reflection. So the self-reflection and action aimed at understanding and transforming the world. So what are the implications for praxis and research? So 3 different levels, the micro, first the interpersonal. So then critical consciousness, us to recognize then structural racism and have this being part of our thought processes. Interpersonally, the awareness of relationships and particularly addressing discomfort with conflict. So, just one small way, we're starting to do this like in my talk, much more powerful if you're doing it in small groups and you're having these honest discussions. And then, partner with the community, and then again, these difficult conversations regarding trust, conflict, and power sharing. The meso organizational level, ensuring equity-focused implementation in operations at Stanford, at Merck Chicago, and then macro structural, the healthcare and public health policies that support the micro and meso level efforts, which we'll talk more about. So another example then, or I guess another solution, this specifically had anti-racist lens then to payment reform. So earlier this year, Kim Singletary and we had a paper that was entitled, what might anti-racist payment reform look like in the AMA Journal of Ethics? So we'll talk a little bit with an example that covers a little bit about access to insurance, payment, and contracts. So the example is the Medicaid program. So I didn't realize this until fairly recently. One of the leading scholars in this work is Jamila Michener, who is I think a political scientist at Cornell. And so it turns out that the Medicaid has a racist origin. And so the political story is that, so 65 Race Society programs, President Johnson, Medicare program was easier to pass because it affects everyone. Medicaid was going to be harder because it would disproportionately benefit people of color and poor people. And so it turns out in terms of the congressional wheeling and dealing, and Johnson this is one of his strengths in terms of understanding the congressional process. He made a deal with the Southern legislators that in return for the vote for the passage of the whole thing, the agreement was Medicaid would be a joint federal state program, so jointly funded by Medicaid for the state and the federal government. Therefore, the states would essentially retain control over the nature of much of the Medicaid program. And then ergo, what you see then in the ensuing years is that the Southern states in particular, underfunding of the Medicaid program disproportionately affecting people of color. So then solutions need to be cognizant of that sort of historical story and why the way things they are now reflect then the history of how we get there. So for example, like, today we could improve the scope of insurance coverage to meet medical and social needs, to cover health-related social needs. The payment could encourage then these partnerships between healthcare organizations and community-based organizations to address structural SDOH in partnership with local governments. There's also like a dual standard. So like a lot of the things for like the public programs like Medicaid require cost savings or cost neutrality requirements for payment innovations, as opposed to value. So for example, you might have an innovation that costs a modest amount of money, but has incredibly great benefits in terms of health outcomes. That doesn't fly, as opposed to like in the private sector. I give you the added Canada example where, things that don't work, are being funded. And then other Canadian examples. So value-based payment and performance-based incentives could reward equitable processes and outcomes. We could provide the upfront funding schemes, so things like capitation, per member per month payments, bundled payments, they could be used to support infrastructure equity. We could risk adjust payment for the social risk of patients, which we largely don't do at this point in time. We talked about that. Expanding the scope in integrating medical and social. I'll actually give one more example. So one of the other programs I was involved with was called Bridging the Gap, working with 8 areas, including a frontier area in northern Idaho to basically integrate medical and social programs to improve diabetes care. And this is beautiful country, but really rural frontier, like 2.8 people per square mile, small town America. And they have a great program where they have CHWs, community health workers, and they partner with the Idaho Food Bank, and they co-locate food distribution with health worker mobile screening to identify medical and social needs. It turns out some of the most marginalized populations, rural populations, they won't come into the clinic. And one few opportunities you have in terms of interaction is at an event like a food distribution event. So very innovative what they're doing, co-locating then the health workers over time to build trust and to do screenings like for A1C and blood pressure and whatnot. A value distributed justice. So John Rawls, and so he had this idea like the veil of ignorance. And his idea was that if you made the rules of society when there was the veil of ignorance, so you didn't know your lot in life, whether you're going to be rich or poor or black or white or Asian or American Indian, the rules that you would come up with would be fairer than if the current system where the people in power have the most say and tend to create systems that advantage people in power. Engaging community authentically, sharing power, addressing mistrust. So there are people on the call that do a lot of community-based participatory research, and it's very important, that element of trust. I would mention this other issue too, that people talk about training, and you got to basically do both implicit bias training and accompany it with the structural reforms for sustainability. You can't just do the cultural company training. You have to do the additional structural reforms. They go hand in hand. Last one I'll mention is, I think it's an interesting one, communication, storytelling, and narrative. And you may have seen this from the AMA and the AAMC. They had this pyramid. So there are messages, like the words and images, that create a story. A collection of stories creates a narrative. Deep narrative is sort of like what's unconscious within us. So things like the stereotypes against Asian Americans, part of that is because there's been a deep narrative created by a lot of bad stereotypes and a lot of bad images over the years that create a deep narrative of what an Asian American is. So teaching about race and racism, upper right there, we talked about language, and this issue of starting with stories and not numbers. So I bet there may not be anyone that may have seen this particular slide. That the Robert Wood Johnson Edition, they commissioned a communications firm to do focus groups with people across the political spectrum, so conservative, liberal, and they came up with messaging and a figure that they found works across the political spectrum. So they talk about structural racism on the left, structural barriers like ignoring lead in the public drinking water, and the right, your public budget funds parks, for example. And then they gave a couple examples of ways to message. And there was this format where first you lead with values, don't lead with data, you lead with values. So we all want to live in a US where everyone has a fair and just opportunity to reach their best health and well-being, no matter their race, ethnicity, or class. Second, positive vision plus problem statement. That can happen by making sure everyone gets quality healthcare from doctors who respect them. It can happen when families live in communities with well-funded schools and parks instead of polluted air and toxic waste dumps in neighborhoods with safe access to safe and affordable homes. We can build a society where people can move up economically and socially, but this is not everyone's reality today. That's because there are barriers built in front of some of us that create unequal opportunity and threaten freedom and prosperity, that end with call to action and unity statement. By joining together, we can unite to create a better future for everyone's children and grandchildren. So I'm going to end with this last story. So this is Judith Sklar, who was one of the best teachers I've ever had. She taught a sophomore course on modern political ideologies, a compelling story. Born, I think, like 1928, 29, Jewish in Latvia, immigrated in 1939. So she just escaped both Stalinism and Nazism. Brilliant scholar. The course was not for the faint of heart. She assigned about 500 pages of original text each week. J.S. Mill, Michelet for Populism, Marx, Adolf Hitler. When she passed away in 92, one of her colleagues wrote that Sklar once wrote that there were two kinds of political scientists: those who study power because they like to exert it, and those who study it because they fear it. Those who would like to ride the horse of power, and those who are scared of being trampled by it. She defined cruelty as deliberate infliction of physical and secondarily emotional pain upon a weaker person or group by stronger ones in order to achieve some end. And she basically said that if we put cruelty first as our guiding principle, with nothing else to excuse us, then we could do pretty well in terms of the rules of society. To put cruelty first, they would therefore be at odds not only with religion, but with normal politics as well. And I would argue that there are two-tiered under-resourced healthcare systems that lead to health disparities for marginalized populations are cruel. Healthcare delivery and payment systems that are not designed to meet the medical and social needs of marginalized populations are cruel. And that systems that accept the status quo and ignore racism and disparities are cruel. Just had a paper come out in Steve Ash's Journal of Medicine, Cruelty and Health and Inequity in the past week or so. And Toni Morrison, she makes these parallels between racism and fascism, that both forms of ideology seek to construct an internal enemy, to isolate and demonize the enemy, to enlist and create sources and distributors of information willing to reinforce the demonizing process, to criminalize the enemy, reward mindlessness and apathy with mind-mentalized entertainments and with little pleasure, maintain at all costs silence. So again, getting back to like the story of my WISE patient, the retired professor. I'll end with a slide that Sklar understood that persistent cruelty more frequently results from the failure of bystanders to intervene, what Dr. King rightly called the appalling silence of the good people, than it does from the outright evils committed by the few. To be serious about eradicating cruelty, we must all use our personal agency to address structural racism and other systems of oppression. Medical, nursing, and social work and public health communities have special responsibilities to exercise such vigilance. Given the severe consequences of cruelty, so does everyone else. So thank you very much, and we have some time for Q&A.
Thank you so much, Dr. Chin. We have kind of questions rolling in from our panel as well as on the webinar. I'll go to Dr. Ash first, Dr. Ash, and actually Dr. Srinivasan after that, because their questions kind of follow each other to ask live. Go ahead.
Sure, Marshall, incredibly inspiring as usual. Really, I feel reinvigorated by your call for personal commitment. I also like the proverb you cited that if you want to go fast, you go alone, but if you want to go far, you go together. And it makes me think, how do we reach out to those, even people within academia and medicine, but certainly people without, who are more skeptical about anti-racism and equity efforts? You kind of touched on that at the end of your talk. What's the most effective narrative for that?
You know, like when I have more time, I add in like bizarrely, I do have this area where we've been using improv, stand-up, graphic medicine, theater, press, teaching about health equity. But one thing I've learned from the people who are experts in this area are that the degree that you could have like people actually meet and discuss and base things in experiential storytelling, that's hard not to sort of be convinced by. It's one thing to talk about things in the abstract, but when you hear the individual stories, including the stories by people that incredibly powerful. So like University of Chicago's journey, like the first thing they did 10 years ago, they actually had a 3-day weekend retreat where they brought together about 30 people from the equity and then like management space, that was a lot of it. Basically, so if you've done it before as a trainee or trainer, you see the power, it's so much more powerful than if you have an hour to do like, a lecture or something like that. And so like, in our students too, they asking more and more for this, like this small group type of thing. So you can do that, with small group type of thing. So like, that's the practical answer. You got to break it down to people meeting people and having the honest discussions from experience.
Thank you.
Malathi, nice to see you.
Thanks.
Hi, Marshall. Great to see you again. Just a wonderful body of work and just so inspiring. I was hoping that you could talk a little bit about polarization within the walls of academia. As you talked about the micro and the meso level, we do have some level of control over things. In the US, there's a movement really to bring care to patients as opposed to having patients come to us. And when we have a country that has very core questions about even basic issues as what is a healthcare right, what is citizenship? What does it mean to belong? How do we actually do what the disability community recommends, which is really nothing for us without us, and invite people to sit at a decisional table in a way that actually can address some of the core issues around structural racism?
Yeah, I mean, 100% agree with what you're saying, Malathi. And I'll give you an example. I used my example of the Robert Johnson Foundation program that revamped our National Advisory Committee, where this new go around, we specifically picked 3 people who either are current or former Medicaid beneficiaries who also have training in activism. Not just one, because one's a token, and it's hard unless you're a very strong person to, be effective. 3, it's changed the dynamic because what that does, it keeps everyone honest and everyone on the North Star, which is supposedly the North Star of a University of Chicago, supposedly the North Star of a Stanford, of improving the health of our patients and communities. If you want, another interesting read that is thought-provoking, Eric Reinhardt has a JAMA network open about unionization of residents, and it gets to some of the issues you're raising of like in a very thought-provoking way, have we bought into a culture of academic medicine, a culture of professionalism that is self-serving as opposed to truly being beneficial for our patients? So the answer to your question is, we just got to do it.
Thank you.
Great. Thanks, Dr. Srinivasan. Dr. Singer, I'm going to go to you next with your question.
Thank you, Stephanie. Marshall, I too really appreciated your presentation. It was wonderful, and especially the comprehensiveness of the solutions that you proposed, having ideas for the micro, meso, and macro levels. Of course, the question that I had for you really focused on the micro piece, and I think about colleagues who are well-intentioned but may be less informed and who may be concerned about making mistakes and being called out for various microaggressions. I was struck by one of the comments you made about discomfort not being a reason for not engaging, and this idea that inaction is kind of not okay. I wonder what you do, how you get that group of people to act.
Yeah, wonderful question. The person maybe I've learned some of the most from regarding teaching about equity is Monica Bella, because she for like over 10 years, she taught the course for first-year medical students that all of them take on equity. So it's basically her, like, every particular challenge and issue and pushback and whatnot. And so the accompanying point is that the coaches, the facilitators, the teachers need to create this safe, brave, yet accountable space. Because, you don't want to be in a situation where, maybe you have a person in Chicago that, is a rural farm kid that hasn't been around a lot of, diverse populations, right? And has honest questions and all. And so, in many ways that I think, and you put your finger on it, I think that oftentimes in terms of like the teaching about health equity, the technical stuff is the much easier part. Or you think of like arts too, it's not hard to teach using stand-up or improv about equity. The harder part is training the facilitators in the issues like moderating a discussion around the tough issues or creating the safe, accountable space. But one thing that there's you see like these checklists of things to say beforehand. This is built over time too, and so it does require then the overall institution to have this as a thing. So you're not moving upstream, so that it's part of the part and parcel of everything that the institution does. The whole buy-in thing. The other thing that Monica taught me too is that I think in general, especially when you have good groups like your Stanford trainees and all, the policing is best and most kindly done by the trainees as opposed to the teachers. So as opposed to Sarah Singer, Malfi, or Steve or I saying, well, and here's the teaching point, and why what you said was maybe not appropriate. It's the peers that do it best, and are generally can be done in a kind but effective way.
I think that's a great idea. I also think about the difficulty of doing this, creating safe, brave, and accountable spaces, and I love that idea in the context of engaging with patients. So we have to find ways of bringing patients into that safe, brave, and accountable space, and to do it quickly. Sometimes we're not dealing with patients who we're working with over long stretches of time, and we've got to work on developing swift trust. These concepts of letting people know what our intentions are, and building the trust in ways that enable them to tell us if we said something wrong without feeling like it was inappropriate for them to do that.
It's a great point, Sarah. And I'll do a shout out to you that one of the things I learned from you and some colleagues too is that the same principles apply regarding internal teams, like a healthcare team and all. So some of these issues regarding voice, power, privilege, same thing. And so, why isn't someone speaking up? If they're the one, more marginalized person and all, or, the junior person. So I think we have our own sort of inward lookings too, that we may think we're being as effective as possible as leaders. And oftentimes there's more we can do. So we're doing our own sort of hard look, and I'm learning a lot in this process also.
Thank you so much, Dr. Chen. I know you mentioned you could stay for like a minute or two. There was one question that got a lot of votes from the audience around non-English speaking patients. So from Dr. Vasquez, who is asking about what's happening nationally to increase reimbursement for equitable care for our non-English speaking patients who often require longer visits to ensure that they are receiving that care. And this will be our last question.
Yeah, it's a wonderful question. I think like, so, there are two ways you can approach this. One is you basically try to create specific targeted funding streams to do this, or like reimbursement codes and whatnot. I'm not aware of that being done right now. The other one, in which maybe there's more wind behind right now, are, in essence, there are large pots of money in the healthcare system. Where that money goes, whether it's, for example, patient care per se, whether it goes to shareholders, whether it goes to, the new orthopedic ambulatory clinic, or does it go to like, the palliative care, center, that is where then it's a matter of both the internal advocacy, of advocating well for our patients and what they need and why, and I would say, throwing you a line there, something that palliative care is really underfunded, undervalued. At the same time that trying to create then advocate for the policies that would encourage a Stanford or UC to do the right thing. So that's why I'm saying the intentionality regarding the payment. So, why not reward, a variety of quality metrics having to do with access to interpreter services, or create some type of incentive structure so that some of that upfront money, like per member per month, there's a clearer bottom line so that it goes to something like interpreter services as opposed to, a less worthy use. We'll put palliative care and primary care in that worthy category too. But so I think there are things we can do in terms of our internal advocacy, our macro advocacy, and then also regardless of whether it is very targeted regarding a funding line for interpreter services to where ultimately the money is in terms of the larger healthcare system.
Great. Thank you so much, Dr. Chen. Thanks for the 100 or so people who stayed with us for the last couple of minutes. We so appreciate you joining us here at Stanford. And I know the recording will be available for those who would like. I know I'm going to dig back through all my screenshots to look at what some of the content and what you've shared with us today. Just for folks on, reminder that next week is not in person. It's still on Zoom, the 5th of July with Dr. Jeffrey Glenn. All right. Have a wonderful Wednesday. Goodbye, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.